So, Dr. Oldham, you had mentioned that a lot of patients who, by the time they get to your practice or the practice of specialists in this area, they've seen a number of other doctors and potentially been misdiagnosed more than once. So what do you do to straighten that out, and how do you work through the process of getting to the correct diagnosis?
Well, for me, like Laura said, when a patient gets to her, there's usually a established rheumatologic diagnosis. When they get to me, there's usually established interstitial lung disease. So I don't have to do much of that work, but a lot of patients still do come to me on inhalers with a diagnosis of COPD or asthma, and simply looking at the lung function tests and the CT scan can help you piece together pretty quickly that the patient doesn't have much in the way of obstructive disease or significant emphysema. And if they're not noticing any benefit from the inhalers and they're paying money for them, it makes sense to stop those. That's probably the quickest and most immediate change in their diagnoses and management that occurs when they see me. But as I said, most patients already have known interstitial lung disease by the time they get to me. And a lot of my focus is spent, trying to categorize what that interstitial lung disease is and how we manage it.
Dr. Danoff, would you say that your experience is consistent with that Dr. Oldham has discussed, or are you getting patients prior to their diagnosis of interstitial lung disease?
Well, we certainly see patients where the concerns about ILD have been raised. I work a lot with the rheumatologists at Hopkins and in our region, and we sometimes have patients who are sent to see us where either there's a new symptom of shortness of breath and there's concern about, again, dissecting whether it's related to interstitial lung disease or some other feature. And then the other thing is we also see a fair number of patients who have a CT for some reason, don't really have symptoms, and get picked up with an asymptomatic or pre-symptomatic radiographic evidence of interstitial lung disease. So we see quite a variety of different patients. And I think that, just as Justin said, the step one is it an interstitial lung disease? Because we also see other things. We see people who come in with heart failure or people who have had some sort of, as you said, Dawn, an insult to the lung where they have a fixed scar in their lung and may not have an active interstitial lung disease or a progressive interstitial lung disease. And so trying to sort that out, and then also trying to identify what an appropriate therapy is, because obviously, amongst our patients, there are many patients for whom we have very effective therapy. We can sometimes think about it like a person who maybe has a hypersensitivity to a parrot in their home. If we can get the parrot out of the house and we can keep them away from, bird products, they could recover perfectly well. And so a lot of what we do also is just really watch the trajectory of symptoms and pulmonary function testing and so forth to really get a better sense of what each person's individual trajectory is.
And to that point as well, sometimes we get referrals in rheumatology where somebody has had an interstitial lung disease identified, and there's something about their history or their workup so far that makes them think, oh, maybe they live in the rheumatic disease spectrum, which actually has important implications, I think, from a prognosis standpoint for their lung disease, but also you want to make sure you're not missing some other part of their rheumatic disease. And actually what we know about the rheumatic diseases are that if we can get somebody kind of phenotyped, put them in the right box, kind of figure out which antibody they make, where they fit in the spectrum of scleroderma or myositis or rheumatoid arthritis, might actually tell us something about what their, not only about other components of their disease that we need to look out for, but how their interstitial lung disease might behave if we can kind of get them into the kind of the right box or phenotype them appropriately. So sometimes we'll get referrals from our pulmonary colleagues and say, hey, they seem like they might fit in the rheumatic disease group, kind of where do they fit? Now, sometimes people just don't fit, and that's pretty par for the course in rheumatology, that there's a lot of gray, but when we can, that can be really helpful.
So I want to ask a question about how you communicate this, not just to the patients, but you are coding for these visits in ways that help manage the trajectory, shall we say, of patient care. Is there a specific ICD-10 code for chronic fibrosing ILD with progressive phenotype?
I
Not
actually
my
don't know
knowledge.
that.
No, either.
I know it's in the works, but I think as of now, it hasn't been developed.
So my understanding, and I've spent some time on the provider side, but also on the payer side, is that there is not yet one, although that I understand one is being developed. But that leads to complexity on the payer side of trying to understand who's treating whom and for what. Is that something that's challenging in your practices?
I mean, I think that it is often challenging to communicate through ICD-10 codes what an individual's trajectory is, because I mean, I think that both Laura and Justin have had this experience where we ask for a medication to be prescribed because maybe the patient hasn't tolerated another medication in this that would have been used before, and we're asking for a more high cost or a more complicated therapy. And it's very hard to actually communicate that through just an ICD-10. So typically what we have is an ICD-10 with a checklist that says, yes, I've tried this drug. Yes, I've tried that drug. No, they couldn't tolerate this drug. But we don't have a really good way of just saying, this has been refractory to therapy, or this has progressed, even in the face of treatment with appropriate therapy. I don't know whether Laura or Justin want to say something about that, because I actually was just dealing with this coding issue earlier today for a patient where I needed to ask for a medication for a prior authorization.
Timely.
Yeah, this in rheumatology is even a little bit more complicated, right? So I mostly take care of scleroderma patients, and so I'm kind of a lumper, right? So I have one diagnosis in my chart for a patient that says they have systemic sclerosis. But what I really need to do to better get medications paid for and testing paid for is I need to say that they have systemic sclerosis, but then I separately need to code that they have interstitial lung disease, and I separately need to code they have pulmonary hypertension, and I separately need to code they have reflux, and I separately need to code they have Raynaud's with ischemic digits to get whatever drug that I'm looking for to treat all those different manifestations of the disease. So it's a lumper splitter problem sometimes in rheumatology, how you do the coding.
I've found this particularly challenging on the rheumatologic side of things, trying to get more expensive immunosuppressive therapies. Now that we have one antifibrotic therapy, nintedanib, approved for progressive fibrosing ILD, it hasn't been as big of an issue thus far. We're only a few months into this process, but it's important to acknowledge that the patients who are studied in the trial identifying nintedanib to be effective in these patients were with patients who had documented progression prior to enrollment. And so, viewing this from a payer side, they certainly are going to want to know a patient is progressive before they approve, an expensive drug like that.